So our programme is quite a complicated programme that really does put the people who use services right at the centre of what we do. So right at the beginning of the programme, we started by designing our theory of change, so the change that we were going to be testing to see whether we could reduce restrictive practice in our inpatient services. And we designed it with people with lived experience of services. So it's people with lived experience, academics in the field, and also clinical staff working. So we started right from the beginning with the people that it's directly affecting. We set up an infrastructure whereby staff would talk to people using the service to understand actually some of the difficulties, some of the challenges for them on receiving care, some of the challenges also for the staff on delivering care within our services. So big things, big changes made by lots of units were things like activities. So patients said, actually it's quite boring here, or actually we need to be distracted from some of the experiences that we're having. So actually people looked at the activities available on the ward and made them wider and lasting for longer time and more days of the week. That was hugely popular. The other thing that we did, which is quite personalised, was to stop as many blanket restrictions as we could. So personalised, be much more personal around those sorts of things. So there were a couple of the big changes that happened. One of my most favourite stories of the original national collaborative was from a PQ in the Black Country. And this gave a really good, for me, example of how the culture on the unit had changed. And the culture had changed into something where people were really walking in our patients' shoes and really looking at the world in a different way. So there was a young man who was admitted to a ward, and he had some hobnail boots on. He was very distressed and quite aggressive, and people were concerned about his boots and wanted to get these boots off. So they spent a couple of days trying to talk to him to take his boots off. And actually this was winding him up more. This is making life more difficult to them. And they got to the point where they thought, actually, the boots really do need to come off, or somebody's going to get seriously hurt here. And then they remembered that they were on the Reducing Restrictive Practice programme, and they thought, actually, we really don't want to restrain this man. There must be a different way of doing it. We're doing this Reducing Restrictive Practice work, and also we think people are going to get hurt if we end up restraining. So they spoke to the lead from their programme, who didn't work directly on the ward, and she said to them, "So has he got anything else to put on his feet?" And they said, "Don't think so." She said, "Give me 10 minutes. She went out, got in the car, went into a department store and bought him a pair of slippers. She came back onto the ward and she said to the staff, "Look, I've got an idea. How's about we have a go at trying to persuade him to take his boots off and put some slippers on, which are far more appropriate for the environment that he's in." And everybody was sceptical. But she went in and she sold these slippers, these lovely fur-lined, comfortable slippers, to this man wearing his hobnail boots. And when she'd finished, he unlaced his boots, took them off, and put his slippers on, and was happy as Larry. So for me, that's just a beautiful example about if you start walking in people's shoes, quite literally in this case, and looking at the world through that individual's, that person's lens, you can create some different solutions that are better for everybody.